Good afternoon, ladies and gentlemen. Thank you for standing by. Welcome to the Chemotherapy Drugs Used in Ovarian Cancer conference call. I would like to remind everyone that this conference call is being recorded on Tuesday, November 17th, 2009 at 7 p.m. Eastern Time. I will now turn the conference over to Ms. Iris Pizon. Please go ahead.
Thank you. Ovarian Cancer Canada welcomes you to this session of our telephone education series for women with ovarian cancer and their caregivers. Today's session, Chemotherapy Drugs in Ovarian Cancer, will be given by Dr. Anna Tinker, who is a clinical assistant professor in the Division of Medical Oncology at the British Columbia Cancer Agency. Whether you are about to receive chemotherapy treatment, are presently receiving it, or have completed your treatment, you likely have questions about chemotherapy and its effects on you. Here's the perfect opportunity to hear what a specialist like Dr. Anna Tinker has to say and to ask questions about the different chemotherapy drugs used for ovarian cancer. I am Iris Pizon, Program Manager of Ovarian Cancer Canada. OCC endeavors to provide women with ovarian cancer and their caregivers the information that they need. We hope that you will find this session interesting and that you will address your questions to Dr. Tinker. To encourage listeners to ask questions, just give a first name. Feel free to provide the operator with an alias if you wish. The previous telephone education sessions are available on YouTube at www.youtube.com/ovariancancercanada, and for the French version, it is at www.youtube.com/ovarcanada. Videos have been posted in 10-minute segments and ordered in parts to make it easy for you to listen, and later return to where you left off. Please subscribe to YouTube. If you like, I would like to acknowledge Alianka Skop for her translation work today. A reminder to the speaker to speak slowly. Today, we are delighted there are survivors, family members, and health professionals from across the country in the audience. We hope that you can help us with your feedback. An evaluation form will be sent to attendees via email or regular mail. And now, please welcome Dr. Anna Tinker.
Good evening. It's certainly my pleasure to be speaking with you this evening. As Iris has mentioned, I'm a medical oncologist at the Vancouver Cancer Centre in British Columbia, and I'm also a clinical assistant professor with the University of British Columbia. My main clinical focus is the treatment of gynecologic cancers, but I also spend a part of my time doing research and teaching medical students and medical residents. So this evening's agenda is to discuss chemotherapy drugs available for the treatment of ovarian cancer. My plan was to divide this evening's talk into essentially three major categories. The first being the type of treatment that women may discuss with their clinicians at the time of the initial cancer diagnosis, the type of treatments which might be discussed when the cancer first recurs, and then the type of treatments that are available when some of our most standard drugs stop working. So to begin with, what happens when a woman is diagnosed with ovarian cancer? The most important first determinant of what kind of treatment might be offered to her is knowing what stage her cancer is at. That's most often known following surgery. And basically, patients are usually divided into one of two groups. They either have early stage ovarian cancer, which is stage 1 or 2, or what we consider more advanced stages of ovarian cancer, which is stage 3 and 4. Stage 1 and 2 cancers are essentially ovarian cancers that remain confined to the ovaries themselves or else only to the pelvic region. So they may spread to the uterus or the fallopian tubes, but they have not spread outside of the pelvis. The more advanced stages of cancer, stage 3 and 4, requires that the cancer was found outside of the pelvic area. So either spread into the abdomen, possibly to the liver or lungs. For patients with early stage disease, a small proportion, probably in the range of about 10% of patients, require no additional therapy beyond surgery. And there may be multiple reasons why this is so. Often it's because their cancer is caught very early and it doesn't seem to have an aggressive behavior based on its look under the microscope. But the vast majority of remaining patients with stage 1 and 2 disease are offered additional treatment. That treatment is called adjuvant treatment, so it's in addition to surgery. The goal of that treatment is to improve the chances of curing the cancer, and it usually consists of chemotherapy using 2 drugs called carboplatin and paclitaxel, or the short form we often use is carbotaxol. Most often, women are offered 6 cycles of those drugs. The situation is a little bit more, requires a little bit more discussion in women with stage 3 and 4 disease. One of the main questions after the initial surgery that your doctor might have is, how successful was the surgery? Meaning, how much residual cancer was left after that surgical procedure was performed. How that is determined is by what the surgeon actually tells us. So when the surgery is completed, the surgeon looks into the abdomen and should indicate whether there's any cancer that was left behind. Often the cancers are left behind because they're in very difficult places to reach, such as above the liver and under the diaphragm, or because they're in places that are dangerous to operate in, such as around blood vessels. If they see some cancer left behind and they cannot get it out, then the standard is to report the size of the lesions that they see. What is the biggest lesion? If none of the cancer lesions or spots are bigger than 1 centimeter, then that's an important thing to make note of. So understanding how much cancer is left behind after surgery can guide some discussion about the next best options for treatment. I should add a caveat here. All the cancer centers across Canada probably have slightly different approaches, and primarily relaying to you the approach we use here in British Columbia. So you may find small variations between what I'm telling you and what your own oncologist might have mentioned to you. It doesn't mean that anyone is wrong or right. It just means that there probably is more than one way to approach the treatment of ovarian cancer. Still, there's a general approach that should be more or less universal across the world, really. So in women who have more than 1 centimeter of cancer left behind after surgery, assuming that they're generally well and should have no serious health conditions otherwise, the standard approach to treatment after the surgery is for 6 cycles of carboplatin and paclitaxel, much like the early stage cancer patients. In patients who have very little cancer left behind, so no cancer that measures more than 1 centimeter, some places across Canada have adopted the strategy of delivering chemotherapy intraperitoneally, so into the abdominal cavity rather than through the blood vessels, which is the usual way of delivering chemo. Usually the drugs that are used for intraperitoneal or abdominal chemotherapy are either cisplatin and paclitaxel, or Taxol, or carboplatin and paclitaxel. There's a variation in the practice across the country, and I don't want to talk too much about the specifics of how the doses and schedules are determined, because every center in Canada has chosen a slightly different protocol, and all of them are probably correct.